Hi everyone. This video is about another very important sexually transmitted infection, which is syphilis. Syphilis is a bacterial infection that is usually spread by sexual contact. The disease starts as a painless sore, typically on your genitals, rectum, or mouth. Syphilis spreads from person to person via skin or mucous membrane contact with these sores. After the initial infection, the syphilis bacteria can remain inactive or dormant in your body for decades before becoming active again. Early syphilis can be cured sometimes with a single shot injection of penicillin. Without treatment, syphilis can severely damage your heart, brain, or other organs and can be life-threatening. Syphilis can also be passed from mothers to unborn children. The cause of syphilis is Treponema pallidum, the bacteria called Treponema pallidum. Clinically, the disease has 3 stages. However, about 50% of people will have no symptoms and will only be diagnosed by serological testing. In primary syphilis, patients may present with a genital ulcer or a chancre that is usually painless. The ulcer tends to be non-tender and usually has a well-defined margin with an indurated base. It may go unnoticed if on anal skin, or on the cervix, or in the mouth. The incubation period for primary syphilis is about 10 to 90 days, with an average of 3 weeks. In about 30% of cases, there may be multiple chancres. Inguinal lymph nodes are usually enlarged, rubbery, and non-tender. Even if untreated, the chancre usually spontaneously heals within a few weeks. As for secondary syphilis, the patient may present with constitutional symptoms, such as fever, malaise, headache, and lymphadenopathy. The skin is involved in over 90% of cases. The rash is usually generalized, involving the trunk, but may just affect the palms and soles. The rash can easily be confused with drug eruptions, pityriasis rosea, or guttate psoriasis. There may be alopecia and condylomata lata, which are warty growths in the anogenital area. There may also be neurological signs of cranial nerve palsies, ophthalmic signs, and meningitis. The incubation period is 2 to 24 weeks, with an average of 6 weeks. If untreated, symptoms slowly resolve over a period of weeks but may recur. In tertiary syphilis, late symptoms or complications may develop months or years later in about 1/3 of cases if not treated. Complications include skin lesions such as gummas, or they're called gummas, cardiovascular or neurological disease. As for latent syphilis, it's divided into early and late latent. In early latent syphilis, which is less than 2 years, implies recent infection and therefore is treated as infectious syphilis. This means positive syphilis serology with no clinical symptoms or signs. Some people never develop symptoms and will only be diagnosed by serological tests. If untreated, people become asymptomatic over a period of 12 to 24 months after initial infection. If any doubt about length of infection, treat as late latent disease. In late latent, which is more than 2 years. After 24 months, people are considered no longer infectious to sexual partners, but women may still pass the infection on to the unborn fetus. Diagnosis is by a combination of serology, history, and clinical assessment. If serology is negative, repeat testing after 2 weeks if clinical suspicion of syphilis. Testing can be done through serology or nucleic acid amplification through a swab of an ulcer. Blood specimens are usually screened with an EIA, which is an enzyme immunoassay. If reactive, RPR, which is a rapid plasma reagent, and TPHA, which is the Treponema pallidum hemagglutination assay, or a TPPA, which is the Treponema pallidum particle agglutination assay, are performed as confirmatory testing. In patients with prior treated syphilis, since the EIA and TPPA tests are usually positive for life, only an RPR test is required to detect reinfection or treatment success. Testing is recommended for men who have sex with men at least annually, up to 4 times a year. It is also recommended for HIV-positive men who have sex with men up to 4 times per year, or at least on each occasion of CD4 or viral load monitoring. It is also recommended to do routine antenatal testing, routine immigration testing, or in cases of a sexual contact of a person with syphilis, there is also the routine sexual health check and the presence of any signs and symptoms of infectious syphilis. The clinical indicators for testing are genital ulcers, men who have sex with men with any genital symptoms or rash, any rash affecting the palms of the hands and soles of the feet, or that is persistent or unexplained. Also, pyrexia of unknown origin, unexplained persistent lymphadenopathy, and unexplained liver function disturbance, and alopecia. Regarding the management of syphilis, early referral or discussion with a sexual health specialist or service is strongly recommended. Patients being treated for primary and secondary syphilis should have rapid plasma reagent repeated on the day treatment is commenced to provide an accurate baseline for monitoring treatment. In cases of infectious syphilis, such as primary, secondary, and early latent, the recommended treatment is benzathine penicillin 1.8 grams IMI stat. Alternatively, procaine penicillin 1.5 grams IMI for 10 days can be given. In cases of non-infectious syphilis, which is the late latent, the recommended treatment is benzathine penicillin 1.8 grams IMI weekly for 3 weeks. Alternatively, procaine penicillin 1.5 grams IMI for 15 days can be given. Intramuscular penicillin formulation used should be long-acting, as short-acting formulations such as benzyl penicillin are ineffective. There are some reactions to treatment that we need to talk about. The first one is the Jarisch Herxheimer reaction, which is a common reaction to treatment in patients with primary and secondary syphilis. It occurs 6 to 12 hours after commencing treatment and is an unpleasant reaction of varying severity with fever, headache, malaise, rigors, and joint pains, and lasts for several hours. Symptoms are controlled with analgesics and rest. Patients should be alerted to the possibility of this reaction and reassured accordingly. The other reaction is procaine reaction, which is a rare reaction to procaine penicillin. It is characterized by a sensation of impending doom with hallucinations. The reaction is self-limiting and lasts for about 30 minutes. The patient needs to be reassured and given general supportive measures. We should advise no sexual contact for 7 days after treatment is administered. We should also advise no sex with partners from the last 6 months in primary syphilis and 6 months in secondary syphilis until the partners have been tested and treated if necessary. Contact tracing should be also done in cases of primary syphilis 3 months back plus duration of symptoms, in secondary syphilis 6 months plus duration of symptoms, and in late latent syphilis only long-term partners. We can also presumptively treat all sexual contacts of patients with primary or secondary syphilis, regardless of serology, with benzathine penicillin 1.8 grams IMI stat. We should also provide the patient with fact sheet and notify the state or territory health department. In pregnant women, only penicillin has been shown to be effective, so those allergic should be desensitized and treated with penicillin. In cases of allergy to principal treatment choice, which is penicillin, non-penicillin regimens have less evidence than penicillin but have been shown to be effective. In cases of infectious syphilis, we can treat with doxycycline 100 mg orally twice a day for 14 days, and for non-infectious syphilis, doxycycline 100 mg orally twice a day for 28 days. As for follow-up, if confirmed sexually transmitted infection, follow-up provides an opportunity to confirm patient adherence with treatment, repeat serology to assess response to treatment, confirm contact tracing has been undertaken or offer more contact tracing support, and provide further sexual health education and prevention counseling. And finally, for test of cure, review all patients clinically and with repeat reactive plasma reagent testing at 3 months, then at 6 months, and if necessary at 12 months after completing treatments. So that concludes this video. Thank you very much for watching. Please like this video, share it with your friends, and subscribe to my channel. Thank you very much.